Good afternoon, my friend. You all are welcome to the ISCH webinar on post-ASH summary. This time we are going to review cellular therapy. We'll start with lymphoma cellular therapy abstract first. Autologous CAR-T, autologous CD19 CAR-T therapies have demonstrated favorable clinical response in relapse or refractory diffuse large B-cell lymphoma, but only a subset of patients experience durable remission. Authors in this study hypothesized that redundancy of CD128 and CD3V signaling in a CAR design might negatively affect T-cell differentiation and may promote exhaustion. Therefore, investigators created new CAR CD19 CAR-T construct with calibration, CAR activation, potentially by mutating one axis. This is a single-center phase 1 dose escalation expansion trial of CD19T2 28Z 1XX CAR T cell in adult patients with relapsed refractory diffuse large B-cell lymphoma. Study was conducted at Memorial, and that's where this CAR T were manufactured. Primary objective of trial was to evaluate the safety, tolerability, and determine the recommended phase 2 dose. 16 patients have been enrolled, treated with a dose escalation phase of the study, all heavily pretreated. You can see here, CRS occurred in almost all patients, 94%, but none severe, and only one grade 1 ICANS. 63% patient had a CR, overall response rate 75%, amazing. CAR T cell were detected beyond 350 days beyond infusion. Data looks impressive, safe, and appears durable response with no relapses observed, no significant toxicity issue. Trial is now moving forward to dose expansion phase with DL1. Another nice abstract, patients with relapsed refractory large B-cell lymphoma after first-line treatment who are unable to undergo high-dose chemotherapy and transplant have a poor outcome. We can't do transplant, we can't do high-dose chemotherapy, and they have a limited treatment option. Axi-cell has recently demonstrated superiority over standard of care as a second-line therapy in Zuma 7 study. Article was published last year in New England Journal of Medicine. Objective of this open-label phase 2 Alicante study was to evaluate the efficacy and safety of Axi-cell in patients with relapsed refractory diffuse large B-cell lymphoma after one prior line of therapy not intended for high-dose chemotherapy and transplant due to either older age or severe comorbidity. 40 received Axi-cell, median age 68 years, more than 45% of patients were more than 70 years. Overall, 93% received bridging chemotherapy because they were progressing after first line, and most patients received GEMOX. 68% were refractory to bridging therapy. Study met its primary endpoint with complete metabolic response at 3 months, 68% versus 12% expected with standard of care based on historical control. Best overall response, 93%, CR almost 80%. Toxicity data were reviewed. 30% patients required ICU care. 4 died due to fatal adverse event, 1 with COVID and rest 3 were with other infection. Axi-cell as a second-line treatment in patients with large B-cell lymphoma who were not deemed candidate for high-dose chemotherapy and transplant is feasible. Nice data. And it induced high response rate. Impressive data, but I think we need long-term follow-up. Disease recurrence and toxicity are common sequelae of CD19-directed CAR-T therapy, well known. Authors have developed a machine learning approach. I love machine learning approach nowadays. That is informative of adverse CAR-T outcome and can support personalized treatment approaches. In a single-center cohort of 198 large B-cell lymphoma patients treated with CD19 CAR-T, Axi-cell 50%, and remaining T-cell and lysocell. 3 distinct biomarker clusters emerge in this machine learning model. Inflammatory cluster, 14%, neutral cluster, 61%, and favorable cluster in 25% of patients. Inflammatory subgroup with high level of inflammatory marker, IL-6, TNF-alpha, ferritin, with favorable cluster tend to have a higher complete blood count and albumin. To determine the clinical implication of this subgroup, authors studied their association with day 100 best response to CAR-T and significant toxicity by day 30 as a life-threatening complication such as immune toxicity requiring intervention, bloodstream infection, or early death. Compared to those in a favorable biomarker cluster, patient in the inflammatory cluster had an increased odds of not achieving CR, nice graph here, by day 100 and high toxicity profile. Patient with neutral subgroup compared to those in a favorable group had a reduced overall survival and increased odds of high toxicity. Love this data. Author concluded that this cluster could guide decision-making regarding hospitalization after CAR-T infusion and to preempt early inflammation and disease relapse in high-risk population. Lysocell is an autologous CD19 CAR-T product administered at the equal target dose of CD8 and CD4 CAR-T, unlike Axi-cell and Tisa-cell. Transform interim analysis Transform study demonstrated that superior efficacy of Lysocell compared to standard of care. Article was published in Lancet last year. At the interim analysis, CR rate and progression-free survival met the statistical significance in favor of Lysocell, and overall survival data were immature at that time. At ASH, author reported result from primary analysis with median follow-up of 18 months. This primary analysis confirmed the clinical benefit of Lysocell over standard of care like other publication. Nice graph here. Data reinforced Lysocell as a second-line treatment in patients with primary refractory or early relapse large B-cell lymphoma. As we all know, fludarabine is one of the most common lymph-node-depleting chemotherapy agent given before CAR-T. There is no place in cellular therapy where we don't give fludarabine most of the time. Because of main pharmacokinetic predictor of fludarabine exposures are weight and GFR, not BSA. I learned from our pharmacist. Standard BSA dose flu leads to high variable drug exposure among the patient. So author in this study, nice hypothesis. Authors in this study hypothesized that variable flu exposure influencing the outcome for patient with relapsed refractory aggressive non-Hodgkin's lymphoma treated with commercial CAR-T. To test this, author estimated flu exposure and evaluated the association with clinical key outcome, aiming to identify a target exposure that optimizes the efficacy and tolerability. Large size study, you can see the numbers. Median estimated flu exposure was 21.1, ranges from IQR was 19 to 24, ranges from 12 to 40. 3 flu exposure threshold, less than 23. Majority of patients fell there, 23 to 25, and more than 25. They were selected based on statistical model. Median follow-up was almost 1.5 years. You can see here, flu underexposure is associated with high risk of disease treatment-related failure, less than 21 underexposure, while overexposure, meaning level more than 25, associated with high risk of toxicity. Author concluded that optimal flu exposure is achievable through personalized PK-directed dosing and is a novel, easily modifiable strategy to improve outcome after CAR-T therapy. Data required further external validation, multi-center, and which is currently ongoing. Nice abstract. Since CAR therapy are produced from circulating auto T lymphocyte in auto CAR-T, the final composition of each product is highly dependent on numbers of T cell and also fitness, meaning function of this T cell. potential deleterious effect of bendamustine on CAR T production has been proposed due to lymphotoxic effect of benda. Based on this, consensus document suggests avoiding benda in potential CAR T candidate. You can see lots of literature and guidelines. However, there is a scarce data regarding the impact of previous benda exposure on T cell kinetics and clinical outcome in patients treated with CD90-directed CAR T. Nice large size study, 370 patients, 20% had received prior benda containing regimen before pheresis. Median interval between last benda dose and pheresis was 226 days. Median total dose was around 1 gram. Median follow-up, 19 months, decent follow-up. Prior benda was associated with low ALC, low CD3 positive cell, and platelets for that time of pheresis. Now, if you look at the data a different way, if patient had benda less than 9 months before pheresis, they had a lower overall survival and low progression free survival, no different in toxicity between the group. So author concluded that bendamustine containing regimen before CAR T therapy may have a negative impact on T cell number and composition at pheresis and on CAR T expansion. Large B-cell lymphoma patient with recent exposure, meaning less than 9 months, to benda have a worse outcome after CAR T therapy than patient with earlier exposure, mean more than 9 months before pheresis. Again, a nice abstract. Clinical trial of axi-cel have demonstrated favorable efficacy compared to conventional salvage therapy for treatment of relapsed refractory large B-cell lymphoma. Paper was published in New England Journal of Medicine last year. In the third or later line setting, a favorable overall survival rate for axi-cel was observed among older patients, meaning age 65 and above, compared to younger patients in a recent analysis that was published by Dr. Karen Jacobson, published in TCT 2022. At ASH, author presented and compared data outcome on, for the first time, effectiveness outcome between treatment with either axi-cel or chemoimmunotherapy in elderly patient in a real world setting. And you can hear many a time, if patient is 3 or more line of therapy, or why not to try chemoimmunotherapy, older patient, so and so. So this is a nice study. 1,146 patients treated with commercial axi-cel for indication, and data was collected from CIBMTR, treasure of data, treasure of everything. And 469 patients selected, they were treated with chemoimmunotherapy with 2 or more line of therapy between 2001 and 14, and data was collected from the Scholar 1 data, and it was an adjusted analysis. Overall response rate, you can see here, 76%, 58% CR with axi-cel versus only 16% CR with chemoimmunotherapy, and benefit of axi-cel, which was confirmed in multivariate analysis. So multivariate axi-cel was associated with significantly or increased overall survival across all age group. This finding further support the broader use of axi-cel in elderly patient, and I have experienced that during my clinical practice. ADI-001 is a first-in-class allo gamma delta T cell, gamma delta CAR T therapy, target CD20. I love gamma delta platform, whether it is modified or unmanipulated. It has both adaptive and innate cytotoxic effect or function to complement CAR targeting, potentially enhancing efficacy and reducing the possibility of tumor escape due to antigen loss, which we can see many times with CD19 loss. It has, so ADI-001 expresses MHC independent gamma delta T cell receptor, so thus lowering the risk of GVHD without need for any gene editing, as for example, TANL technology, many products have used to knock down the gene or to reduce the risk of GVHD. Small study, but impressive data. 11 patients 8 large B-cell lymphoma. 4 patients had prior anti-CD19 CAR-T, 2 each lysocell and exa-cell, minimal toxicity, overall response rate 80%, almost all CR. In patient with prior CAR-T, 100% response rate. At data cutoff, 2 patients progressed, 1 died in CR. Encouraging data. We need to keep eye on this gamma delta for CAR-T. More to come. Now, another abstract, if you look at the original XCT cell study, less than 25% patients in the initial registration trial were older adult, age of 65 and above. So real-world data on the survival and toxicity outcome of older patients receiving CAR-T are limited. So author used the CIB registry data, again, treasure of data, to study the impact of age on response, survival outcome, and incidence of toxicity after CAR-T, commercial CAR-T. Almost 2,000 patients receiving mostly exa-cell, 75%, and remaining received T-cell 25%. Median age 63, maximum 91 age. 76% patient had 3 or more line of therapy. 45% patients were more than 65 years of age. Bridging therapy was used in about 25%, which is also common experience by most centers. Mostly chemotherapy-based bridging therapy, 75%, but 25% patients received radiation-based bridging therapy. No impact of overall survival, progression-free survival, relapse, and CRS. By age. Increased rates of any grade CR icons with annual increase in age, which is not uncommon. Author concluded that CD19 CAR-T therapy is feasible for older patients that with advanced age does not impact the mortality. With cautions also, advanced age should prompt anticipatory management of neurotoxicity. If you see something grade 1, attack it. Comorbidity may impact the outcome also, which also we need to keep eye on it. Let's review the comorbidity now in CAR-T recipient. Pre-existing comorbidity score like HCT-CI, which is connected with my friend Mohammed Sorer, have been shown to be associated with morbidities and mortality following transplantation. Now, impact of comorbidity on CAR-T therapy is not well studied. There are some small studies. At CIBMTR, authors sought to develop and validate CAR-T therapy specific comorbidity index called CTCI and examine its prognostic value in predicting survival and toxicity outcome. Nearly 2,000 patients included in this analysis. 25% patients were more than and above 70 years of age, and 20% patients had KPS of less than 80%. Treatment-related mortality was low, 4%, as expected. Higher CTCI score associated with worse 1-year survival. Other factors, common factor, low KPS, resistant disease, PR, poor outcome. Significant comorbidity and CTCI were not associated with development of toxicity, meaning CRS and ICANS. So author concluded no development of novel CTCI has been shown that comorbidities are predictive of mortality after CAR T-cell therapy and may influence clinical decision for the treatment of specific selection in high-risk population. Another study on the same subject, anti-CD19 CAR-T and anti-CD320 bispecific antibody have emerged as a most promising agent for the treatment of relapsed refractory large B-cell lymphoma. We're going to see now top line, bispecific versus CAR-T. We don't have much in lymphoma, unlike in myeloma recently approved, but we have several CAR-T approved. And we do have a mosunetuzumab approved for follicular lymphoma, and we expect that glofitamab and apocritinumab for diffuse large B-cell lymphoma will be approved sometime soon. So we will have two very effective choices. However, we don't know optimal sequencing of both treatment and it's still matter of debate. Complete response with bispecific around 30% and response rate in the range of 60% has been reported in a patient treated with failing CAR T therapy. Given their promising efficacy and accessibility, bispecific may be given only in the future therapy strategy, because then many community oncologists can give it without, and unlike in CAR T, where you will need to have CAR T delivery certification to be IEC certified center. So most centers will try to give bispecific even before CAR T therapy. So, but today there is no data regarding the outcome of patient treated with CAR T cell after prior exposure to bispecific in lymphoma. So this study included 32 patients from DESCAR-T registry data, 28 eligible patients for analysis, median of 4-line prior therapy. 90% of patients had a refractory disease. Prior bispecific, mainly CD20, CD3, mainly glofitamab. Best overall response was 54%, CR 25%. So after CAR T, again, this was prior to bispecific, and after CAR T, best response rate was 93%, you can see here, and CR was 50%. 1 year progression-free survival is 30%, overall survival 53%. CRS and ICONS no higher than compared to published data. So author concluded that data showed efficacy of CAR T appears preserved in those patients with disease progress after bispecific. Nice, again, one more study. King's College London data showed improvement over time in survival outcome in large cell lymphoma treated with CD19 CAR T. And this is also we experienced nationally, which appeared to be mainly driven by improvement in bridging therapy. Well-prepared patient, meaning we're preparing patients very well before we take them to the transplantation CAR T nowadays. And incidence of high-grade CAR T toxicities are also low. Seems to be further reduced with more preemptive or proactive toxicity management in recent era. As we discussed before, older patient, we know high risk for neurotoxicity. We don't wait longer to give them treatment. So great comfort zone nowadays. More you get, like many centers have more comfort zone for haplotransplant. Some center will have more comfort zone for cord blood. So now CAR T getting more comfort zone at most program. And you know when to act to prevent life-threatening complication. Time to action is very important for the success. To minimize the toxicity associated with axi-cell, several exploratory safety management cohorts were added to ZUMA-1 study. ZUMA-1 cohort, 1 cohort, 2 cohorts, there are several cohorts. In cohort 6, 40 patients published in British Journal of Hematology, or Dr. Olwale from my program, our program is first author. Prophylactic was used as corticosteroid beginning on day 0, 1, and 2, as an intervention strategy to decrease grade 3 CRS and ICANS. No grade 3 or higher CRS was observed in this study, and also no grade 3 or higher ICANS observed only in 13% of cases, without any difference in outcome. That means steroid did not compromise the long-term outcome of patients with relapsed refractory CAR T after CAR T. Paper was published, as I said, in 2021. And in this study, authors sought to establish the real-world pattern of prophylactic steroid use and clinical outcome. So what they did was they sent 5-question survey to 22 centers across the US, axi-cell certified treatment center. 50% of centers using prophylactic steroid. No significant difference in efficacy or CAR T associated toxicity were noted in between the two groups, unlike what was published in a cohort 6 ZUMA-1 study. Potentially due to selection of patient, potentially due to selective use with patient at a presumed to be high risk of severe CR CRS and icon. So patients select, you don't use it. And that's what the most prefer to do. What I prefer to is use it older patient with comorbidity, prophylactic steroid. If I have a young and robust patient, I would prefer not to use it. Severe cytopenia. In the current study, author investigated the incidence of severe cytopenia and its clinical impact after therapy with commercial CD19 CAR T-cell product in patients with large B-cell lymphoma in Europe. Study endpoint was incidence of severe cytopenia in first 100 days after CAR T infusion. Nice numbers, more than 300 patients, large B-cell lymphoma, post-CAR T, EBMT data. All patients with full data set were included in this analysis. Severe cytopenia, meaning grade 3 or 4 toxicity. Cumulative incidence of severe cytopenia was 10%, 11% at day 30, and about 14% at day 100 after CAR T. Most patients had either pancytopenia, almost half, or isolated neutropenia, almost half. 46% suffered from prolonged severe cytopenia without resolution until day 100 after CAR T. However, severe cytopenia had no significant and overall survival. This data provide insight on frequency and clinical relevance of severe cytopenia after CAR T therapy for diffuse large B-cell lymphoma. CAR T therapy is widely used in relapsed refractory large B-cell lymphoma, and now with approval for second-line use, early user. CRS is commonly seen in after CAR T therapy. It can lead to increased cardiovascular circulatory demand. Lots of CAR T use, and CRS is not uncommon. So when CRS, meaning pro-inflammatory milieu of CAR T cell, which leads to coagulopathy, endothelial damage, myocardial stunning, which may lead to major adverse cardiac event, or cardiac arrhythmia, which you also see after transplant. Recent single center and pharmacovigilance studies have reported increased risk of major adverse cardiac event, as well as arrhythmia, especially atrial fibrillation. I would say this is an additional information to exist in literature, nothing novel, but very important because it's a nicely conducted study to assess cardiac toxicity after CAR T. 71 patients treated at Cleveland Clinic. My friend, Dr. Brian Hill, the last author, 3 of 71 patients, 4% developed major adverse cardiac event, 11 patients, meaning 15% developed atrial ventricular arrhythmia. To contrast to previous report, author found low rate of major adverse cardiac event, probably due to better selection or better patient's medical management before taking them for the transplantation. Again, one more nice abstract. After 2 commercially available CAR T products became available, many patients are receiving CAR T as a third-line therapy. I have heard many transplanters will say, why not to use allo rather than doing CAR T? We have a good outcome. And I used to say this before, not now anymore. Authors sought to compare the data from EBMT registry, focusing on relative role of both treatment approach in patients receiving third line or beyond for treatment of relapsed refractory diffuse large B-cell lymphoma. 1,500 patients, almost 600 patients had allo, almost 1,000 patients had CAR T. Patient group different significantly because of indication and patient's characteristic. More advanced disease, older patient in CAR group compared to in allo where we select the patient. CAR T for more than or equal to 3 live treatment after diffuse large B-cell lymphoma have a better overall survival and progression-free survival than patient receiving allo transplant in this adjusted analysis. Relapse incidence was higher after CAR T because they had a disease compared to allo transplantation, but lower non-relapse mortality after CAR T. Patients with active lymphoma like LDH high IPI prior to CAR T show higher relapse incidence and significant decrease in overall survival. This effect was less strong in allo patients. So author concluded that allo transplant remain a valuable option, especially in patients with high-risk disease characterized by what we discussed, high API and high LDH. I'm not sure. You don't want to take patients with bulky, actively progressing disease for allo, because they will progress more after immunosuppressive allo transplantation before graft versus lymphoma effect kicks in. Nice patient, again, real world data. If you look at the prior publication, suggested that reduced wait time is associated with increased efficacy, paper published recently last year. Here, author assessed the real world impact on vein to vein time on after axis-cell in relapsed refractory large B-cell lymphoma. Vein to vein meaning pheresis and infusion of CAR-T. Shorter vein to vein time, pheresis and CAR-T was associated with favorable CR rate and overall survival, and reduced risk of prolonged thrombocytopenia even after adjustment of key prognostic factor. So based on statistical model, vein to vein interval compared with less than 28 versus more than 40 and in between. ICANS of any grade was higher in patient group with less than 28 days vein to vein interval, but higher grade ICANS, means grade 3 or higher, was no significantly different. Overall, this finding highlights the importance of shortening vein to vein time in patients receiving XLS. Nice graph here. You can see green line is more than 40 days, vein to vein interval with inferior survival. Now, if you look at the data, today cytotoxic chemotherapy is commonly applied as a bridging therapy prior to transplantation or to CAR-T. We reviewed CIBMTR data, almost 75% received chemo-based bridging therapy to mitigate the heavy tumor burden. Optimal bridging treatment is still not known, unknown. Mostly, as you said, 2/3 receives, 3/4 received chemotherapy base. So, but some case series or small case reports have indicated that the radiotherapy priming CAR-T strategy shows some potential advantage, but no large series. So in this study, author analyzed the safety and efficacy of radiation bridging, radiation therapy-based bridging therapy with or without chemotherapy, compared with chemotherapy-based bridging prior to CAR-T in large B-cell lymphoma. Chemotherapy bridging was in 31 and radiation-based bridging was in 29. Radiation therapy as a bridging strategy was demonstrated to reduce the incidence of severe CRS and improve progression-free survival. And this was a trend. But radiotherapy can improve progression-free survival and overall survival in patients with bulky disease. And this is what my preference would be. Nice graph here. Red line indicates radiation therapy as a bridging therapy. As you know, ZUMO-5 is a phase 2 multi-center single-arm study. I'm sure everybody has memorized now all those published New England Lancet paper. It's axis-cell in patients with relapsed refractory indolent non-Hodgkin's lymphoma. Author presented long-term data at ASH meeting. 159 patient, majority follicular lymphoma, 3-year progression, 3-year follow-up study, ZUMO-5. Showed continued, you can see the graph here, continued durable response, nice graph. Late progression or death due to lymphoma or study-related treatment related deaths were uncommon. You can see nice splitter graph. No new safety signal also. This study aimed at investigating not CRS, not ICANS, organ complication of commercially available CD19 CAR-T in patient treated, adult patient treated with large B-cell lymphoma. Almost 400 patients analyzed for organ toxicity. Again, my favorite group from ABMT. Overall, the frequency of severe, meaning grade 3 or higher organ toxicity during the first 100 days after CAR-T was very low. Data reviewed here. They could not do advanced statistic analysis due to small number. Message is it's low, severe toxicity, organ toxicity, other than CRS and ICANS. Low frequency of severe organ complication in adults after CAR-T therapy in this real world EBMT large series data. Lymphodepleting chemotherapy is typically given on 5th through 3rd day before CAR T infusion, meaning day -5 to day -3. However, in real world practice, cell infusion may be delayed. We can't give it on day 0 sometime because of multiple reasons, include clinical reason or logistic reason. It remains unclear whether delaying cell infusion impact the clinical outcome and whether lymphodepleting chemotherapy should be repeated if cell infusion is delayed. I'm sure you have experienced this in your clinical practice. Sometimes you have to delay scheduled CAR infusion after lymphodepleting chemotherapy. Large study, 240 patients, 17% received dual infusion. Median delay was 2 days, ranges from 1 to 14 days. Otherwise, beyond 40 days, you may need to repeat the lymphodepleting chemotherapy, depending on many criteria. Common reason for delay, infection, 85%. And otherwise, disease-related procedure like doing paracentesis, thoracentesis, biopsy sometime, and logistic complication. Caregiver could not come. Patient had some issue to travel, many other reasons. But infection main. Delay was associated with high rate of prolonged severe cytopenia and worse clinical outcome, especially if delay is more than 1 day. Now, if patient has an active infection, that's the most common reason for delay. We can't give CAR T. I guess would have more detrimental effect if we give a patient as active ongoing infection. Nice graph here. You can see for your review later. Let's switch gear now. Let's switch gear to multiple myeloma. Nice oral presentation. Outcome of ID-cell in patient with early relapse after auto. As you know, KarMMa-2 is a multi-cohort, phase 2 multi-center trial of ID-cell in relapse refractory multiple myeloma and in clinically high-risk multiple myeloma, defined as early relapse after frontline therapy, which was in cohort 2A and cohort 2B, or inadequate response after frontline auto, it's cohort 2C, and we're going to review all. The efficacy and safety of ID-cell in cohort 2A are presented here. Early relapse after frontline auto. 87% had a double refractory disease. Overall response rate was 86%, CR 46% after ID-cell, and majority of patients had MRD negative after CAR T. A patient had early relapse after frontline auto and received CAR T infusion for myeloma. Ideal cell treatment demonstrated frequent and deep response in patients who experienced early relapse after frontline auto transplantation. MRD negativity was sustained in subset of patients even beyond 18 months post-CAR T. Author concluded that these results support a favorable clinical benefit risk profile of ID-cell and its potential use or as an early line of treatment. Another nice abstract, back-to-back oral presentation was there. CAR T therapy targeting BCMA have resulted in unprecedented depth and duration of response in relapse refractory multiple myeloma. However, relapses are frequent. We know that after CAR T, many myeloma patients relapses, and development of novel approaches is still critical. We need to continue to get better. So GPRC5D, orphan receptor expressed on myeloma cell with limited expression on other tissue, has emerged as a promising therapeutic target for myeloma. GPRC5D directed CAR T therapy demonstrated promising initial efficacy, safety in patients with relapse refractory myeloma. Sarah Melanoscodi published paper in Blood 2 years ago, about 2021. Author presented interim analysis, interim result with dose escalation part A, phase 1, first in human, multi-center open label dose finding study evaluating this CAR T therapy, auto CAR T GPRC targeted. 21 patients enrolled in 17 patients received the product. 12 of 14 evaluated for initial 1 month clinical outcome, overall response rate was 86%, including patient treated with prior BCMA targeted therapy. 4 out of 6 who had BCMA directed therapy responded, and BCMA directed CAR-T therapy, 3 out of 5 patients responded. Favorable safety profile like other product, and still dose escalation is ongoing. As we all know, ide-cel received regulatory approval for treatment of patients with relapsed refractory myeloma after 4 or more prior line of therapy based on result from pivotal KarMMa trial. Dr. Munshi was first author. Paper was published in New England Journal of Medicine in 2021. Patients who had previously received BCMA targeted therapy were excluded from KarMMa trial. They thought it might give inferior outcome probably. However, author in this study evaluated the real world outcome for patients treated with standard of care ide-cel after who had received prior BCMA targeted therapy. 50 patients, ADC was used in 38 patients, bispecific in 7, and CAR-T in 5. Heavily pretreated, median regimen was 9. Patients received prior BCMA targeted therapy, had a lower overall response rate, 74% versus 88%, and it was significant, and lower best response rate, CR or beyond, 29% versus 48%, compared to those without prior BCMA targeted therapy. There was a trend toward worse efficacy outcome who received ide-cel less than 6 months after initial prior BCMA targeted therapy. Author concluded that timing of ide-cel infusion after prior BCMA targeted therapy warrant further investigation. Again, this was a similar abstract. Author presented data on long-term follow-up of cohort C patient with prior non-cellular anti-BCMA immunotherapy, CAR-T2 data now. Efficacy and safety of CAR-T. Here, cilta-cel in patient with progressive myeloma after exposure to non-cellular anti-BCMA immunotherapy. Similar to previously reviewed abstract, data showed favorable response, but the depth and duration of response appear lower than those who were anti-BCMA naive group. So data may inform us treatment decision plan, including sequencing and washout period between BCMA targeted agent. As we all know, MRD is a prognostic, very important prognostic for survival in myeloma, well established. MRD is usually assessed in the bone marrow by flow or NGS, and guidance is also available for MRD assessment by PET-CT to provide global representation of tumor and to evaluate for response in the extramedullary myeloma patient. So author examined MRD prognostic value using combined both bone marrow and PET-CT early after CAR-T at 1 month. Key point of the study, MRD stated at 1 month post-CAR-T prognostic for prolonged progression-free survival. The rate of dual MRD negative bone marrow and PET was lower than MRD negative alone in the bone marrow. Progression-free survival is longer for patients with dual MRD negative versus only bone marrow. Highlight the need for additional intervention among patients with evidence of residual disease early after CAR-T. So this will identify prognostic significance at day 30 if you don't have double MRD negative. But I don't know how this is possible outside the clinical trial. If you do PET-CT at day 30, payers won't let you do another PET-CT for some time. And many a times you can get twice PET-CT in a year. Otherwise, you'll be on phone doing P2P for a long time, very expensive. Bispecific CAR-T therapy has proposed to mitigate some limitation of single agent CAR-T therapy. CS1 plays a vital role in myeloma pathogenesis and is associated with is highly expressed on tumor cell in almost all patients with myeloma. Small study presented outcome of 16 patients with relapsed refractory phase 1 clinical trial using bispecific CAR-T. Novel small size study, overall response rate was 81%, including 6 patients with stringent CR. 1 patient with grade C CRS, no icons, great safety profile, 12-month overall survival 84%, progression-free survival 55%, duration response 69%. CAR T cell infiltrated into tumor tissue, but the response was not observed in 3 patients with extramedullary disease alone. Author concluded that clinically active product with good safety. However, further studies are needed for patients with extramedullary disease alone. As we all know, this data was just published in Nature Medicine, I think on January 24th. Data from phase 1 universal study of ALLO-715 for treatment of relapsed refractory myeloma. I'm not going to go into detail of benefit of auto versus allo or advantage, disadvantage, but we know allo CAR is an off-the-shelf product and comes with some advantage. 2 DL3 cohorts were chosen for expansion using lymphodepletion of FC plus ALLO-647 at 2 dosing, 39 milligram, 60 milligram. 53 patients reported in this study. Time from enrollment to lymphodepletion was very short, 5 days. None received bridging therapy. 19% had extramedullary disease, no GVHD, no DLT. CRS was 53, all grade 1, 2. ICONS only 11%, all grade 1, 2. Overall response rate, 80% with FCS 60 using ALLO-647, 60 milligram, optimal dose for them. 50% achieved VGPR or higher, 20% received CR or stringent CR. Viral infection was the issue reported, and low-grade viral reactivation were very common. I think we need more data and to design what prophylactic antiviral medication we can consider. And we also need long-term data. Look at this study, Miriam. My favorite, whether you want to spend 50,000 plus upfront or 500,000 plus upfront, US dollar, I mean. Induction chemotherapy followed by either auto or CAR-T. Very practical study. Randomized open label global multi-center phase 3 Imagine CARTITUDE 6 study aim to compare DVRD, cilta-cel, and line maintenance versus DVRD, auto, DVRD 2-cycle consolidation, and line maintenance. Target population 750. Cilta arm, patient will undergo pheresis before receiving 6 cycles of DVRD induction. I'm hoping we are going to have some data in next few weeks. Let's review key point of this study, very important. Factor predicting failure of CAR-T in US myeloma consortium study. Potential predictor of early progression after CAR-T in relapsed refractory myeloma, prior BCMA-directed therapy. We reviewed 2 abstracts. There were a few more also. High-risk cytogenetics, which is very well known, and elevated ferritin at the time of lymphodepletion. Outcome results are here. You can see nice graph. Presence of 2 of 3 factors negatively impact progression-free survival and overall survival after CAR-T therapy. As we all know, KarMMa-2 is a multi-cohort phase 2 multi-center trial of ide-cel in relapsed refractory myeloma and clinically high-risk myeloma, which we defined before. Efficacy and safety of ide-cel in cohort C now. We reviewed cohort A before. In cohort C, patients with myeloma who had inadequate response to frontline therapy with auto transplantation were presented at ASH. Single or tandem auto, inadequate response as defined as less than VGPR at day 70 to day 110 days after last auto. ide-cel was successfully manufactured and infused in almost all patients except 1. Among 23 of 31 patients who achieved CR or higher after ide-cel, 70% patients had MRD negative at 6 months. 63% had MRD negative at 12 months, and 11 of 16 MRD negative at 20 months. Author concluded that early deep clearance of tumor seen in patients with ID cell treatment early used for early failure after auto-transplantation, and response was sustained in beyond 2 years in many patients. Love this abstract. As we all know, patients with renal insufficiency were excluded from registration clinical trial. Relapse renal insufficiency impact a significant proportion of patients with myeloma, and safety and efficacy of CAR-T remain unknown in this population. We do see lots of referrals with renal insufficient consideration for CAR-T, but we do have some data, good data. Author evaluated in this real-world outcome of patients with renal insufficiency treated with standard of care ID cell. Of 211 patients received ID cell, 13 had a renal insufficiency. 39% of those 13% had a severe renal insufficiency, meaning creatinine clearance less than 30. Renal insufficiency could have older patient, more prior line of therapy. Fludarabine dose was resisted in majority of patients as expected. CRS, ICONS, ICU care, infection, severe cytopenia, no different between the group. No worsening of renal insufficiency after ID cell, but improvement was noted in some patients with severe renal insufficiency. Only issue was renal insufficiency group had a longer hospital stay and were more likely to be experienced short-term high-grade cytopenia. And as a precautionary, we try to keep them longer even after transplantation if you have some complication. Renal insufficiency had overall response rate of 96% versus 83% without. CR rate was 58% versus 65%, and VGPR plus 77 versus 65. In multivariate analysis, renal insufficiency was not an independent predictor of progression-free survival. Studies support the feasibility of ID cell, CAR cell, meaning in relapsed refractory myeloma with renal insufficiency. Low ALC studies, low fractionated ALC study also. Study evaluated the impact of pre-apheresis, pre-lymphoablation, peripheral blood ALC on post-ID cell outcome in large cohort, more than 200 patients. Pre-apheresis and pre-lymphodepletion ALC were not significantly associated with PFS and overall. However, for patients with high ALC reduction between pheresis and CAR-T infusion was associated with worse outcome at 6 months. If you have a drop in ALC between pheresis and CAR-T, worse outcome. And this is a time we do give bridging therapy, may be associated with more aggressive disease biology and need for more aggressive bridging therapy. And this is a nice graph. What we need to know is association between specific bridging therapy, which reduce lots of ALC, impact on ALC reduction and outcome. Let's switch gear briefly to AML cellular therapy. Not much, but we need to keep eye on some of those abstract. Small size study, because AML is future myeloid malignancy for cellular therapy. As you know, the results of CAR-T in AML are lagging behind, mainly due to absence of AML-specific target agent, or maybe due to associated resistant issue like upregulation of PD-1, IPMC-induced myeloid-derived suppressor cells, many things. Universal CAR-T treatment consisting of universal CAR-T cell with CD28 co-stimulatory domain and CD123 targeting module. But both unique CAR-T as well as the targeting modules are individually insert and has an individual activity, can only be activated when both are present. Next study, next concept. 14 patients, 12 received CAR-T, not much CRS or neurotoxicity, good count recovery in most patients, good, very good reduction in bone marrow blast. 2 patients received CRI, 4 had a PR, small study, but treatment proved to be safe and tolerable with limited toxicity. Expansion cohort is going, and I think we need to keep eye on this study. Another nice abstract, ASH22 version 1.2, genetically modified allo T product manufactured from the healthy donor cell. Selective steal-in technology used to minimize the risk of graft versus host disease, CD9, like allogen product and other products have used, and allow use of anti-CD52 directed therapy as a lymphodepletion. MLE-01 is a phase 1 open-label dose escalation trial evaluating the safety, tolerability, expansion, and persistence of UCART123 version 1.2 given at the escalating dose after standard lymphodepletion chemotherapy. But alemtuzumab was added to lymphodepleting regimen to sustain host T and NK cell depletion. That's a problem many a time, because if host T and NK cell come back, it will reject donor CAR T. And it in here to give campaign to promote engraftment of UCART 1.123 version 1.T and give expansions and persistence. Early data, only 16. 8 patients had FCA lymphodepletion, meaning with campath, alemtuzumab. Patient in dose level 2 FCA, which achieved greater than 90% bone marrow blast reduction at day 28. FCA LT lymphodepletion result in a robust lymphodepletion and UCART 123 expansion. I think this is also interesting study to keep eye, because look at the disease characteristic in this study. Almost all high risk. Let's wait for the outcome data. Hopefully they will present something at the ASH. We have reviewed before, challenging in developing CAR T in myeloid malignancy. One of the main challenges, current target of myeloid malignancies are widely expressed on many hematopoietic cells. CAR T cell could cause lasting bone marrow depression. Therefore, to receive a balance, author designed a CD19 CAR T to recognize EML and using NK cell to replace T cell to eliminate T cell. CD33 CAR NK cell, I love this concept, have combined advantage of tumor-associated target CD33 and safety of NK cell. Okay, early data, 10 patients only. In dose level 3 and 4, patients received 3 rounds of CAR NK at interval of every 7 days. Minimal toxicity, 6 out of 10 patients achieved MRD negative CR at day 28. We made them eligible, authors, they made eligible patients for transplantation. Author concluded that efficacy needs expanded sample and long-term follow-up. Several other abstracts, mainly preclinical or early phase clinical trial, small numbers for your reference here. Let's switch gear briefly to Hodgkin's lymphoma abstract. Innate cell engagers. Cell engagers are coming everywhere nowadays, as you know. AFM13 combined with pre-activated and expanded cord blood-derived NK cell for patients with double refractory CD30 positive lymphoma. As we know, AFM13, if you Google it or if you go to their website, it's first in class CD30, CD16A bispecific antibody construct that induce specific and selective killing of CD30 positive tumor cell by engaging and activating NK cell. As a single agent, AFM13 had a limited clinical activity. So the author designed this new to get the NK engagement. Presented data on 30 patients. All patients had active progressive disease at the time of enrollment. No bridging therapy. Cord units were selected with no consideration for HLA match. No toxicity, as you can see here. All 24 patients treated with recommended phase 2 dose had a response, 100% oral response rate and 71% CR rate. 5 patients had responder patient underwent auto transplantation, median follow-up of 8 months, and decent survival data listed here. But I think we still need a good long-term follow-up and study outcome at some other centers too. CD30 CAR modified Epstein-Barr virus-specific T cell. CD30 CAR EBV-ST provides safe and effective off-the-shelf therapy for patients with CD30 positive lymphoma. Authors have treated 14 patients with relapsed refractory Hodgkin's lymphoma. Patient had undergone a median of 5 prior therapy, escalating dose of CD30 CAR EBV-STs after standard lymphodepletion. The issue was qPCR for CD30 CAR transgene showed near background level by week 1 post-infusion, meaning all CD CAR T disappeared by day 7. But 70% had a response rate. Some of the explanations are listed here. Nice data. We need expanded and long-term data multi-center level. Again, this is all very well-known study trial, Sharia trial, some data published before. Autologous CD30 CAR T therapy in patients with relapsed refractory classical Hodgkin's lymphoma, progression after at least 3 lines of therapy, which include failure after chemo, brentuximab, and PD-1, which is a standard nowadays. 17 patients, median prior line of therapy, 6, response rate 73%, CR 60%, 77 patients received second infusion, and they have all responded with 60% CR. Minimal toxicity, good expansion, and persistence after infusion. Impressive data. Let's follow this study for now. Let's review a few other diseases and supporting care briefly in last part of the session. Allotransplant recipients are highly susceptible to reactivation of double-stranded DNA viruses. I call them cockroaches. Approximately 70% of high-risk allotransplant recipients develop clinically significant infection. Author presented results from phase 2 trial evaluating the safety, efficacy of posoleucel, a partially HLA match, off-the-shelf, multi-virus-specific 6-virus T cell, which is an investigational product to prevent clinically significant infection due to this commonly seen 6 viruses after transplant. High-risk allotransplant recipients were defined as we common definition, haplo, cord blood, mismatch unrelated, match unrelated, but had a low lymphocyte before transplantation, as well as who received T cell depletion. To be eligible, patient had to be engrafted within 15 to 50 days after allotransplant, and patient should not be on high-dose steroid for advanced acute GVHD. Patient received up to 7 infusions of posoleucel once every 14 days. Data showed 8 patients, 31 had acute GVHD, grade 3, 2 to 4. Not surprising because these are all high-risk transplant patients. Patient who received posoleucel had lower than expected rate of clinically significant viral infection from 6 targeted viruses, despite observed and expected low level of viral reactivation throughout the study. Repeat dosing of posoleucel was safe and well tolerated. Posoleucel VSTs were detected in vitro. Remember, up to 26 weeks, almost 6 months. And reconstituting T cell demonstrated functional specificity for multiple viruses. Job is done. Placebo-controlled trial, global phase 3 trial is ongoing. High-risk malignancies are difficult to treat. This is very interesting study. My most favorite oral presentation at the ASH. HLA mismatch, unrelated CD8 depleted CD4 positive DLI to induce remission in patients with AML and secondary AML and MDS. Remember, off-the-shelf And these are not prior allo transplant. DLI after chemotherapy. It was intentionally class 2 HLA mismatch to activate donor 34 positive T cell to promote potent anti-tumor response. Eligible patients include relapsed refractory to at least 4 cycles of HMA, 9 patients, 8 with secondary AML, 4 with TP53, which we are still looking for good outcome, median age 66, no dose limiting toxicity, CR in 2 out of 3 in dose level 3 and 1 out of 3 in dose level 2, all underwent allotransplantation. Now, people will ask, what about donor DNA in the bone marrow? No donor DNA in bone marrow post-chemotherapy DLI before patient underwent allotransplantation, so all recipient. So no problem with GVHD after allo. CR patient had a higher inflammatory marker, IL-6, IL-2, IL-15, gamma interferon, TNF-alpha. Induction chemotherapy, this is author's conclusion, followed by CD8 depleted HLA mismatch, unrelated DLI was feasible and well tolerated with no DLT, and I give congratulations to authors. Now, while non-Hodgkin's lymphoma are decreasing among patients living with HIV, NHL remains the leading cause of cancer attributable death in patients living with HIV. And risk of NHL remains significantly increased in people living with HIV. People living with HIV have been excluded from the registration trial based on HIV status from landmark trial, as you know. Therefore, information on safety and efficacy with this potentially curative treatment in living with HIV data is limited, only a few case report. We had a case last few weeks ago. We had to find the literature and we could see one or few case report using Axicel. So it's a collaborative effort between AIDS Malignancy Consortium and CIBMT. That's where we can find the data. 30 patient history of HIV received CD19 CAR-T. 45% were African American plus Latino. Data on 21 patients from 13 centers available. 95% received Axicel. Time from HIV diagnosis to CAR-T was median time, 117 months. Pre-CAR-T CD4 count was 228 days. It ranges from 0 to 252, mostly more than 200. No added toxicity, all is resolved, as expected. CRS icons all resolved. 6-month survival, 64%. One died of bacterial infection beyond 6 months, which we had seen in also HIV after autotransplantation, HIV, history of HIV before. In this interim analysis with limited follow-up, CD19 CAR-T therapy appears safe, effective in people living with HIV, similar to report in patients without HIV. However, study is ongoing. We need more data and long-term data. SLE, very interesting again, is an autoimmune disease that is based on dysregulation of adaptive immune system, autoantibody production, and immune complex mediated tissue damage. While treatment of SLE has substantially improved, subset of patients, and I'm sure you have seen, experience severe progressive disease, life-threatening, with T and B targeted therapy. Treatment is also toxic. The study in this author aimed to achieve deep depletion of B cell using auto CD19 CAR-T with goal of achieving immunological reset and drug-free remission. Small size study, but impressive data. This is a beginning, I would say, before it opens the floodgate. 5 patients, 4 female, refractory SLE to all possible treatment, including belimumab. Sufficient number of CD19 CAR were produced in all patients. All patients developed CRS, all grade 1, WBC recovery by day 14. Remission of SLE per Doris criteria, very strict criteria, in all 5 patients after 3 months, including laboratory response with disappearance of anti-double-stranded DNA autoantibody. Large and long-term studies are needed. Another SLE abstract, small, but just to keep eye on it. One patient out of these 3 patients presented with 9-month follow-up after CAR-T, young female patient now off all therapy. For your information, Kivema, K-Y-V-E-M-A, chemotherapeutic submitted IND for novel CAR-T therapy to treat lupus nephritis. Also, I will refer you to the editorial written by Professor Carl June in Cell, CAR-T therapy extend its reach to autoimmune disease. Please read this one. Now, this is an important abstract. We presented before also during last ASH review. Tab-cel, off-the-shelf allo-EBV specific T-cell immunotherapy investigated for EBV PTLD. ALILI phase 3 multi-center open-label global registration study. Author presented report and updated outcome of 43 patients at the ASH. No fatal treatment emergent adverse event. Consistent with previously presented data, response rate was 51%. PTLD after liquid transplant 50%, PTLD after solid transplant 52%. Median time to response, very short, 1 month. Median overall survival not treated. Updated data confirm that tab-cel provides consistent clinical meaningful benefit outcome. Tab-cel is potentially transformative treatment advance for those patients with relapsed refractory EBV positive PTLD for whom there are no approved therapy, and we had one experience with good outcome. Again, because of time constraint, I'm going to give you references of some of the abstract, supportive care abstract presented at the ASH. If you still have access to the presentation or ASH access, please review. Otherwise, review the abstract. Nice abstract on supportive care after CAR-T therapy. I thank you very much for your attention, and I'll be happy to answer your question, but via email. Thank you again. Thank you so much. Flu dose reduction. Are you following flu SMPC guidelines for dose modification of flu in lymphodepletion if GFR is less than 50? So if you look at the one abstract I presented, renal insufficiency abstract, CIBM data. So they defined renal insufficiency as a GFR less than 50 and severe if it is less than 30. Generally, we don't do, but if it is less than 50, definitely we do prior to lymphodepletion, where we use fludarabine for 3 days. For transplant recipient, where we give 5 days or more, 30 per meter square, where definitely we do with renal insufficiency fludarabine dose modification. And I hope I answered your question. The next question is, for indolent non-Hodgkin's lymphoma, the ZUMA-5, given the nature of disease, for how long you need to see the stable PFS curve, like Plato, after CAR-T to be convinced that it is working? We don't know, nobody exactly, but look at this ZUMA-5 clinical trial publication or data. Most patients were very advanced. 2 or more line of chemotherapy, which includes chemoimmunotherapy. So most patients had like R-CHOP and R-bendamustine, so similar regimen. And then they were enrolled into the ZIMA trial. And you can see now it has plateaus. To me, if I have to guess, I think they will remain like this. So we will hear some more information, updated data, maybe next year or maybe in 2025. But this is my prediction. I think we are done. It's plateaued already now. Let's do one more last question. Regarding pancytopenia rate after CAR-T, CD19 ALL treated patient, you mentioned about 50% of cases. The question is, we talked about there is no increase in mortality in this abstract. But if you look at the abstract very carefully, I think abstract number 26, it was EBMT data, but it was a first 100 days mortality and assessment. It was not a long-term cytopenia assessment. So I agree with you. On a long-term follow-up beyond 100 days, there will be patient dying from infection if they have a severe pancytopenia after CAR-T therapy. And again, I thank you very much for your attendance, and I'll be again happy to answer. If any question, please shoot me an email. My email is bipin.savani@vumc.org. Again, thank you so much.